Let's start.
Do you want to turn off the lights?
Yeah, the front ones if possible.
Oh, we can't turn the light. We
Huh?
have to turn it off.
Yeah, go ahead. Okay, Bismillahirrahmanirrahim. Any questions from the last lecture? I mean, any problem that you faced before we begin? Nothing? All is fine? This was not the one, I guess.
That's the one. That's
This was not the one. Can you bring it back? Yeah. Can I have the lights on again? I think probably I took the wrong.
okay.
Yeah, I think I copied the wrong folder. Can you just bring it back? Maybe. Yeah, renal imaging too. I think you picked up the wrong one.
Okay, so
So you picked up the first one. Yeah, this is the one. Okay, thank you.
share.
You just check if everything is okay.
Okay. Thank you.
Okay, so the last lecture was just an introduction, and we discussed few things, the common ones like stones and infection. So today we are going to build on that, and we're going to discuss tumors and trauma cases. So this was the slide which we left last time, and I probably went through it hurriedly, so I just need to sort of rediscuss this slide. So I said there are sometimes congenital anomalies, meaning that the kidney might not be in its normal location. So the first one I said is an intrathoracic kidney. So the right kidney is not seen in the lumbar region and is lying up in the chest. Okay. So this one is a cross-fused ectopia. So instead of having a right kidney, the kidney has gone to the other side, congenital that is, and has fused to the lower pole of the left kidney. So the right kidney is actually this kidney, and this one is the left kidney. So both are sort of fused together, another congenital anomaly. In this case, the kidney is lying in the pelvis. So again, congenital anomaly where the kidney should not be lying in the pelvis. Someone asked me, is it a transplant kidney? Yes, sometimes we do have transplant kidneys placed in the pelvis where you attach the iliac artery and the vein, and obviously they drain into the urinary bladder. But this one is a congenital one, so you'll see absence of the native kidney. So you'll not see the native kidneys in cases of congenital anomaly. If it's a transplant kidney, you might see some remnant or an atrophic part of the kidney in its normal location. Then this is the this is fused kidneys lying again lower in the pelvis. This is known as horseshoe kidney. So horseshoe kidney, does anyone know why does this happen? Some say it is a genetic gene abnormality. So the kidneys sort of fuse at the level of inferior mesenteric artery. So they are lying just in front of the spine. So obviously they are sort of malrotated and more chances of stasis of urine more chances of infection, more chances of stone formation, and then also chances of malignancy, the renal cell carcinoma. You'll see examples of this later. So this is when you have the kidneys lying together, fused in front of the spine. So we discussed all this. So now let's begin with the renal masses. So this is an example of a 55-year-old man who had an ultrasound, and a kidney cyst of 3.5 centimeter was seen with a septum, internal septum. Septum is a thin structure, thin cord-like structure inside the cyst. The septum has perceptible enhancement. Perceived means it's not actually measured enhancement. So it looks like that the septa is enhancing after contrast. So, but it isn't sure whether it is enhancing or not unless you measure the enhancement. So you do a plain study and then you do a post-contrast study. And if there is difference of Hounsfield unit of around 15 Hounsfield units, then you say that there is enhancement. So perceptible enhancement means to the eye, it looks like it is enhancing, but we obviously did not measure it on CT. So no solid component seen in the cyst. There's no calcification in the cyst. So what is the most appropriate management? So the question is what to do with this cyst. Should you leave it alone, or should you follow it, or should you consider it as something abnormal? So obviously, when you face a situation like this where you have a fluid-filled cystic area in the kidney, then you need to know whether there is any chance of malignancy. So how do you know that? Obviously, through cases, through going through a lot of studies, then you collect data, and then obviously through that data, you identify which cysts in the kidney have chances of malignancy. So Bosnick actually tried to classify these cysts. This is known as Bosnick classification. It's an old classification, but there has been modifications in this. But the basic concept is that to try to identify which cysts are to be followed up or to be considered as malignant. So main objective is to identify which cysts to leave alone and which ones to be considered as chances of having malignancy. So the 5 categories are 1, 2, 5. Obviously, the 1 and 2 are considered as benign. So benign means these cysts can be left alone. So if you look at this cyst, obviously the size is also important. It should be around 3 or 3.5 centimeter in size. Anything less than that, it doesn't fit into the Bosnick classification. So 3 centimeter size cyst, which is anechoic. Anechoic means jet black color, because fluid is obviously black on CT. So this is a classification which is based on contrast study, that is CT scan. You can also use MR to evaluate this cyst, but obviously the more frequent or easy one available is CT scan. So with CT scan, the cyst is anechoic one, doesn't show any enhancement of either the wall or any septa inside. Now, if you have a cyst with a septa inside like this, very thin septa, like the one I showed you previously, hardly perceptible one. You see there's a septa here. You see a thin sort of line drawn inside the cyst. So this is known as a septa. So there's a septa inside, but obviously there is no solid component or no enhancement inside the cyst. So this is again Bosnick 2. So 1 is when you have nothing inside the cyst, either a septa or a solid component. 2 is when you do have when you can see a small septa inside. Now, 2F is a sort of subcategory of 2 where you do see septas, but these septas are not the simple septas. That means the thickness has to be considered. If they are thick septas or they are more than 3 or 4 septas inside the cyst, then these are not simple cysts. Then we consider them as a cyst which has potential of malignancy. So in literature, it has been reported that from 5 to 10% of cysts that are in this category, that is 2F, that means the ones having 3 or more septa inside, and these septas show enhancement. So when you measure these septa enhancement, By enhancement, I mean you do a plain study and a post-contrast study. And then you measure whether there is any difference between the pre-contrast and the post-contrast study. So if the septa shows an enhancement of above 15 Honsfield units, you consider it as something positive. Now, these cysts, again, should not have any solid component inside, because if there is a solid component inside, then it places these cysts in category 4 like this. You see, if you have a solid enhancing component inside, then it becomes category 4, which is obviously a malignant cyst. Category 3, again, is one cyst with multiple septas, 4 or more septas, which are thick. So the septa can be thick, the wall can be thick, which can be enhancing inside. There can also be sometimes calcifications associated with these cysts. Now, the potential of malignancy in Bosniak 3 is from 40 to 60%. So again, this is a significant amount of cysts that can turn malignant. So you cannot leave alone Bosniak category 3 cysts. Okay, so the wise decision would be to sort of excise or get rid of these cysts, because 60% chance of malignancy is a significant chance. Okay. So what do? The 1 and 2, you just ignore them. If you have cysts of these 2 varieties, you just leave them and you just sort of tell the patient that these are benign and you don't need to worry. But if you have a cyst with 3 or more septas, which can be thin and thick and sometimes do show enhancement and can also have calcifications inside, then you need to follow them up. So if there is any change over a period of time, say 3 months or 6 months, then you can either upgrade them. If their change is significant, like if there is a solid component developing, then you can upgrade it to 3 or 4, depending on what you see. Now let's see some examples of this in order to understand it more carefully. Again, Bosniak 1, this is just another diagram showing you category 1. The 2F I told you, if you have septas, 3 or more, with the thickness of the septa should be around 2 mm. It shouldn't be more than 2 mm. If it is more than 2 or 3 mm, then it places it into Bosniak 3, like here. 4 mm septa would be Bosniak 3. That obviously is malignant. Chances of malignancy are more. And 4 is when you have solid enhancement inside along with the septas. Now, this is a cyst where there are few calcifications in the wall. Okay, so if you have just the calcifications, no septa or no solid enhancement inside a cyst, then it is considered as Bosniak 2. So Bosniak 2 is a benign entity. So you can leave alone these cysts. If you don't see any enhancement or any septa inside, just the calcifications in the wall, you can leave alone. Consider it as Bosniak 2. Okay, so this is when you have a solid enhancement inside a cyst. You see, there is an enhancing. This is obviously contrast given. The rest of the kidney is enhancing. So along with that enhancement, you also see some enhancement inside the cyst wall. So this is Bosniak 4. When you see any enhancement which is significant inside a cyst, consider it either going to be 4 or 3. So you cannot leave alone these cysts. What about this cyst inside the kidney? Again, this is a post-contrast study. You can see contrast in the rest of the kidney, but there is a cyst inside compared with the normal on the other side. So this cyst has enhancement inside, and you can see that there are these thick, irregular shaped septas, not the smooth septas that you saw in category 2 or 2F. So there would be thick nodular enhancement inside along with the septas enhancing. So this is category 3. So when the septas are thick, irregular, and you see enhancement, then it is category 3. Are you clear on this, everyone? So just to sort of recap, the 3 and 4 categories are considered as the malignant potential ones. So the 3-1 is when you have thick nodular enhancement inside a septa. So they can be 4 or more than 4 septas. In category 4, for category 4, you have a solid enhancing component like this one. So any solid component inside a cyst automatically shifts it to the higher category. Okay. Okay, so again, let's see a few examples. Now there's a cyst in the left kidney. You can see this is a post-contrast study. You can see enhancement in the rest of the kidney. There's also contrast in the aorta and the IVC. So this cyst does not enhance. Again, if the cyst doesn't enhance, it is a simple cyst, which is category 1. Okay, so leave alone. What about this cyst now? It's a big cyst, obviously more than 3 centimeters in size. And what about, you see that it is displacing the kidney anteriorly. So this is the left kidney, and the right kidney is sort of displaced by this large cystic lesion inside the right kidney. And if you look at the walls of this cyst, they are not smooth walls. They are sort of irregular, and you have this soft tissue component inside. So whenever you have a soft tissue component, again, it's suspicious. So once you give contrast, this will enhance. And any enhancement, any solid component inside the cyst will make it category 4. So chances this should be considered as a malignant cyst and should be excised. What about this now? You see, this is the left kidney. And what about the right kidney? There is a mass that has grown out of this kidney, and it is extending outside the contour of the kidney. So normally the kidney should be here like this. So this is growing outward. So it's extending beyond the contour of the kidney. And if you look at it, some part is enhancing like here, but some are not enhancing. Again, say some heterogeneous or patchy sort of enhancement here. So again, when you have a heterogeneous sort of enhancing mass arising from the kidney, this is more likely to be a renal cell carcinoma, which is the most common tumor in the kidney, okay? So why do we have these areas which are not enhancing inside the renal cell carcinoma? Yeah, so you would have no blood supply. Why would you have no blood supply to that area? Necrosis, yes. So the tumor can have parts where it has necrotic tissue that would not take up contrast. So these areas suggest that these are necrotic areas and are not taking up contrast. So don't mix them up with cysts. Obviously, cysts would not take up contrast, but the necrotic areas would also not take up contrast. Okay, so there's a lesion along the lower pole of the left kidney. Again, it has a cystic component and has a solid component which is enhancing. So which category would this be? 3 or 4? 4. Because in the third category, you'll just have thick septas inside. So any enhancement inside a kidney would make it category 4. Okay, so this is a horseshoe kidney. You can see that the left kidney and the right kidney are sort of united in front of the spine. And there's a mass which is arising on the right side. So what do you think? Is it a cyst? Doesn't look like a cyst. Why? Because it isn't black like the rest of the cysts that you saw, which were not enhancing. So there is enhancement inside. So when you see enhancement inside, it's not a cyst, then it's a solid mass, okay? So this is a solid mass, and the more likely tumor to be is renal cell carcinoma. So horseshoe kidneys, as I've said, have chances of infection, stone formation, and cancer formation. So, and they can also be injured easily because it's lying low anteriorly in the pelvis. So easily, if someone hits or gets injured, blunt trauma to the lower pelvis can injure these kidneys. Okay, so multicystic nephroma. This is a tumor which is a cystic tumor, and it's not a very frequent tumor because it's seen more in children. So it has 2 peaks. You see them either in the early age in a child, or you can see in the later part of the life, like in adults from 40 years onward. So you will have a cystic mass and would show you similar sort of appearance like category 3 or 4. So if you look at these images, there's a large cyst here. Again, you see internal septations which are enhancing. So this is a multicystic nephroma, okay? So you can also, again, you see that there are these septas inside which are enhancing. Again, septas inside which are enhancing. So you have to be careful. You can see this in children, or you can see it in the adult age after 40 years of age. So it might not be just a simple cyst. This can be a multicystic nephroma. So it's a cystic RCC sort of tumor. You can also have calcium in 10 to 15% of cases. Okay, so let's talk of the solid tumors now. We talked of the cystic lesions. If we have a solid tumor, and this is the necrotic part which is not enhancing. But rest of the tumor, you can see that is heterogeneously enhancing. So any enhancement is not going to be a normal thing inside a mass. So if you look at the other kidney, this is the normal kidney on the other side. You can see some part of the normal kidney here and some part here, but this is all tumor which is growing outwards. So it's going beyond the contour of the left kidney. So the most likely to be is renal cell carcinoma. 90% in adults, it's going to be renal cell carcinoma. It's more frequent in the males. Okay. Again, the same picture I showed you early, renal cell carcinoma. If you do an IVP for the patient, you look at this normal collecting system. You see the calyces, the renal pelvis, the ureter. But what about this side? You see that there is some stretching or splaying of the calyces. So as if there is a lesion here, which is sort of putting pressure over the calyces. So sometimes you would see blunting or amputation of the calyces. So you would see that there is no contrast that is to be seen in the collecting system. So you see there is a mass which is here, and it is putting pressure over the mid and lower pole calyces. So they are sort of stretched out because of the mass which is there in the kidney. So this mass is actually stretching out the renal calyceal system, which is the normal calyceal system. So this is how you see on IVP. Obviously, when you see abnormal calyces like this, you would do an ultrasound or you would do a CT scan to stage the tumor. Okay. So once you do a CT scan, again, you could see sometimes a mass like this. Again, the necrotic areas are not enhancing. Some part is, majority of the lesion is enhancing, like rest of the kidney. Okay. And again, it would tell you, it would help you in staging of the tumor. If you look carefully, you can also see few lymph nodes in the para-aortic region. So obviously the stage, or for staging of the tumor, you need to know exactly where the tumor is, because obviously the surgeon wants to know whether this is resectable or not. We'll talk of this later, where we will sort of stage or tell you how, which tumors can be resected. The same information you can also get on MR. Okay. Again, another example of renal cell carcinoma. You see there is, again, the central necrotic part is not enhancing as much as compared to the rest of the surrounding margins. So now the important thing is to know how to stage it. So the things that to look for is these 6 things: renal vein invasion, IVC invasion, perinephric invasion. So that means does it extend beyond the renal contour into the perinephric fat? Is it limited by the capsule of the kidney, or it has gone beyond the Girota's fascia, which is the perinephric fascia? Okay. Are there any lymph node enlargements? Are there any para-aortic or regional lymph nodes? And is there any involvement of the adrenal gland? So if the lesion is lying in the upper part of the kidney, does it invade the adrenal gland, or does it metastasize to the adrenal gland? So these things you must know, because obviously the stage of the tumor depends on all these findings. So how would you do this? How would you know whether renal vein or IVC invasion is there? You need to give contrast, because if you see enhancement inside the renal vein or IVC, it rules out thrombus inside. Okay. So let's see a few examples now. This is the left kidney enhanced, which is normal. You can see the ureter here, normal ureter here. Now, if you look at the right kidney, again, this is, you see a very heterogeneous sort of lesion here. Again, heterogeneous lesion. And if you look carefully, you can see that it is sort of extending medially. So this is actually aorta, and this is the IVC, and this is the renal vein. So it has actually gone into the renal vein. It's the tumor extending locally or infiltrating the renal vein, and it's extending into the IVC. So when you have this, obviously the stage is going to be stage 3. We'll talk of the staging later. Let's see another example. This is a 41-year-old. The patient has a tumor in the right kidney. It's quite large kidney because of this tumor. This part is not taking up contrast. The rest of the lesion is taking up heterogeneous contrast. If you look at on the contralateral side, again, you see another mass here. Okay. And there's a mass which is arising from this kidney as well. So you have actually bilateral renal masses here. One is in the right kidney and the other one is in the left kidney. So if you look carefully, this is the liver. And again, you have a lesion in the right lobe of the liver. Okay. So you have a lesion which is quite large in size. So this is actually a right renal cell carcinoma, but this is an advanced cancer which has spread not only to the liver, but it has also metastasized to the contralateral kidney. So it has gone to the other kidney and to the adrenal gland. So adrenal gland is going to be lying at the top of the kidney. So it's an advanced tumor which has, it's a stage 4 tumor which has gone beyond the confines of the kidney. Okay. So how do we actually stage? We'll see this again. The reason for doing staging, as I said, is partial nephrectomy. So we want to sort of save the kidney if possible. We want to get rid of the tumor, and if the rest of the kidney can be salvaged, we want to do that. So when do we say that this is resectable? When we have a small tumor, less than 3 centimeters in size, it does not invade the perinephric fat, so it is limited by the capsule. It doesn't go into the collecting system, the renal collecting system, that is the pelvis or the ureter. It doesn't go into the renal vein, because obviously if it goes into the renal vein, it's going to be stage 3. So we don't want this. We don't want all of this. And obviously, if it's stage 4, then you would see distal metastasis. So we don't want it to be going to the, or invading the surroundings viscera, or going to the other organs. Like it should not go to the bones or to the lungs. So let's see this staging now. Stage 1 is when it is limited inside the capsule of the kidney. So it's inside the renal parenchyma. It can be up to 7 centimeters in size. Stage 2 is when the tumor goes beyond the capsule. It has invaded the capsule, but does not invade the Gerota's fascia, which is the perinephric fascia. Remember the kidney? There's a fat around it, which is known as perinephric fat. And then I showed you the fascia in the last lecture. Those fascias are actually limiting the disease process. So if it goes beyond those fascias, then it is obviously going to be stage 3. Sorry, it's going to be stage 4. If it goes into the renal vein, like the one you saw earlier, or it has metastasized to the lymph nodes in the para-aortic region, then it's going to be stage 3. So the easy way to remember it, if it's confined in the kidney, it hasn't gone beyond the capsule, it's stage 1. If it is going beyond the contours but limited by the fascia, that is the Gerota's fascia, then it is stage 2. If there is renal vein invasion, IVC invasion, or lymphadenopathy, then it is stage 3. And obviously stage 4 is going to be when it is advanced. So that means it has either gone to other viscera, or it has gone beyond the Gerota's fascia. Okay, clear on this? So let's see now different examples. This is stage 1. This is without contrast. Once you give contrast, you see there's a heterogeneous mass which is not enhancing like rest of the kidney. So this is a heterogeneous enhancing mass in the right kidney, and it is limited by the renal capsule. So it hasn't gone beyond the Gerota's fascia. And obviously the size is less than 3 centimeters. So this is a potential candidate for partial nephrectomy. This is when the tumor is stage 2. Obviously, the tumor size is more than 3 centimeters. There are a few necrotic areas. Again, heterogeneous enhancement inside. It is going into the perinephric fat. So it is infiltrating the perinephric fat, but hasn't gone beyond the Gerota's fascia. So it is in stage 4. So are there any lymph nodes? If there are few lymph nodes, then it is going to be stage 3. But in this case, there are tiny lymph nodes here, probably. So they do not satisfy the lymphadenopathy. They should be around 1 centimeter in size. So this is a case of stage 2. So it is within the, it has gone beyond the capsule, but obviously it hasn't invaded or, the Gerota's fascia. Now, this is when it is stage 3. You have very large, juicy lymph nodes, very large size lymph nodes. Again, this is the aorta, this is IVC. So this is a structure which is not a vessel. Again, a heterogeneous mass showing necrotic areas. So when you have lymph nodes associated with the lesion, it's going to be stage 3. This is tumor in the right kidney. It has gone beyond the gyrota fascia and has locally invaded the liver. So obviously there is local spread. So if it goes beyond the renal confines, beyond the gyrota fascia, invades our surroundings viscera, it is stage 4. Okay, sometimes you would have cystic renal cell carcinoma. These are around 10% of renal cell carcinomas. So some can be cystic as well. You can have again, but they are more or less like category 4 of Bosniak. Okay, so you would have cystic area and then you would have enhancement in some part of the tumor. Again, some majority of the lesion would be cystic, but there would be some enhancement inside. Again, another cystic renal cell carcinoma. Another example of renal cell carcinoma, where you have thick wall, enhancing wall with enhancement inside the cyst. Okay, these renal cell carcinomas are, they are less frequent, but they have the malignant potential is less compared to the ordinary RCCs. Okay. In children, remember, the more frequent tumor is going to be Wills tumor or nephroblastoma. Okay, and usually in the first or second decade, they present with a large mass, sometimes like this, and you can see that the kidney is sort of stretched around it. If you see some part of the kidney which is stretched around it, it gives you a sort of claw appearance. Okay, so these are childhood tumors. If you remember the rule of 10, does anyone know what is rule of 10? No? 10% can be malignant, 10% can be affecting the other kidney. They have more malignant potential. I think 10% of them metastasize. So, all 10, 10, 10. So this is the rule of 10, which is used for Wilms tumors. Okay. And what else do we need to know? Yeah, they are very similar to sort of renal cell carcinomas, but, in a child, they present sometimes very late. They're detected very late. So the child, usually when you do an X-ray, you would see a sort of soft tissue mass on X-ray. Once you do an ultrasound, the lesion would be very large in size. So it'll be, lying or covering the whole abdomen sometimes. They can also, 10% of them, they can cross over to the other side. 10% of them calcify. So, rule of 10 is sort of used for these Wilms tumors. You have to differentiate it from neuroblastomas, which are tumors arising from the adrenal gland in children. So the more common ones are going to be either Wilms or neuroblastoma, and you have to differentiate between them. Remember, the neuroblastoma is, since coming from the adrenal gland, it would sort of invade or, it would invade the kidney. Whereas Wilms tumor is coming from the kidney, it would displace the structures. Okay. And obviously, it can also cross over to the other side. Another example of Wilms tumor, another large tumor, and some part of it is necrotic. And you see some tissue, which is normal kidney, that is stretched around it. So claw sign is sometimes very helpful to identify. If you see a claw sign around it, it helps you in differentiating it from neuroblastoma, which is the other common tumor. Again, a claw sign that you see around it. If you see some part of the, sorry, this is not the claw sign. This is splenic vein. Sorry, it's the kidneys here. So it's just to, don't mix it up. I don't know why I put this here. This is a sort of splenic lesion. Okay. Claw sign is this one. You see some part of the kidney that is around it. Okay. Another tumor to remember is renal lymphoma. Okay. Usually they can be seen in immunocompromised, and obviously there are a few other manifestations, like you would have lesions in the spleen, there would be splenomegaly, there would be large lymph nodes in the body, like they can be in the para-aortic region or other parts of the body. And then you would also see sometimes lesions inside the kidney like this. So they can also give you sort of striated pattern, like the ones you saw earlier in the last lecture, when I said the striated pattern is a feature of pyelonephritis. Okay, so acute pyelonephritis can also give you a striated sort of pattern. So if you have lesions inside the kidney giving you striated pattern, and both kidneys are sometimes involved, also think of lymphoma as a differential. Obviously, the history would be very helpful. In pyelonephritis, you would have all the features suggesting infection, whereas lymphoma, you would not have features of infection. And then if you do a CT scan, you might see lesion inside the spleen. You might see some lymph nodes in the body. So all these can sort of point out to the lymphoma. Another example of lymphoma where you have bilateral masses inside the kidney. You see there are these masses which are not enhancing like rest of the kidney. Again, another mass here, another mass here, bilateral masses in the kidney. And then these are the lymph nodes here. There are also lesions inside the liver and the stomach and the spleen. So multiple lesions in different visceras, think of lymphoma, because lymphoma would affect all organs. If you see large paraortic lymph nodes like this, sort of sandwiching the mesenteric vessels, then again, this is more likely to be a lymphoma. So this is a mass inside the kidney. And with that, you see all these paraortic, juicy, very bulky lymph nodes. Again, lymph nodes inside, this is all lymphoma. So it has to be put together in the whole picture. You have to see whether there are lesions in the spleen, in the liver, in the paraortic region, are there lymph nodes? And then you would usually see sometimes lesions in the kidney as well. Again, bilateral lesions. It's an example of lymphoma in an AIDS patient. So immunocompromised patients can also develop lymphoma. Now, the fat-containing lesions are usually the ones which are considered as benign. The most common one is going to be angiomyolipoma. So angiomyolipoma, it is, angio means from vessels, myo means from muscles, and lipoma means from fat. So it has all these three components. So it will have vascular component, it would have smooth muscle component, and would also have fatty component. So these are, if you look carefully, there's a fatty lesion here, small lesion here in the left kidney. This is a small angiomyolipoma, whereas this fatty component is a large lesion inside the right kidney, and it is displacing the kidney medially. So you see this is a large fatty component, and it also has a soft tissue component, which can be the smooth muscle component. Okay. So these are benign lesions. The problem with this is if they are small in size, nothing to worry. You can leave them alone. But once they are more than 4 or 5 centimeters in size, the chances are that they might bleed someday. Because obviously they are made up of vessels which are not normal vessels. They tend to form aneurysms sometimes, and these aneurysms can bleed inside. So if you have a large lesion, more than 4 or 5 centimeters in size, then you need to follow up these patients just to be wary that they might bleed someday. Okay. So this is another angiomyolipoma in the kidney, which is the right kidney. And if you look carefully, there is some fluid around it. So this has sort of bled inside. So sometimes you would have, bleeding as a complication of angiomyolipoma. As I've told you, these are abnormal vessels inside these tumors, which are leaky sometimes and form aneurysms and can bleed. Another example of angiomyolipoma, this is a small one, no need to worry about this one, because once they are small, then very unlikely that they can bleed. They are more common in people with tuberous sclerosis. Okay, the phakomatosis, you can read this, few conditions where they are seen bilaterally in the kidneys. Few more examples of angiomyolipoma. You see that there is fat. Why do we say fat? Because if you compare it to the subcutaneous fat, it is the same density. If you measure the Hounsfield units there, it will be in negative. Again, a fatty lesion, black. Okay. Another fatty lesion here. Okay, so this one has, again, some tissue around it. So chances are that this has bled. So once the lesion gets larger in size, more chances are hemorrhage developing inside angiomyolipoma. Okay, so the last tumor which we need to know is the urothelial tumor or the transitional cell tumor. It arises from the lining, more common in the urinary bladder, but it can be in anywhere in the collecting system, in the ureters or in the renal pelvis. So it will give you a filling defect. Once you give contrast and you have a delayed nephrogram or an excretory phase, you see a filling defect inside. So if you look at it, there is this filling defect in the upper part. So you need to see whether there is a tumor lying inside, or is there a tumor lying in this part. So if you do a IVP, it will give you a filling defect. But then obviously you do a CT, you will be able to tell what is the reason for this filling defect. usually you would see a filling defect in the collecting system like this. And you do a IVP or you would see stretching again of the calyces like this. It would produce mass effect over the calyces, and sometimes can even result in amputation of the calyx. So you will not see the contrast filling up the calyx, because obviously this lesion is lying inside the collecting system. So it cannot, the excretory phase would not take up contrast. And if again, this is filling defect inside the renal pelvis, filling defect again going into a dilated renal pelvis. So it's also resulting in hydronephrosis. Okay, so a tumor, usually these do not take up, these tumors do not enhance like renal cell carcinoma. So they'll give you a black filling defect inside. Again, a filling defect inside the renal pelvis. You see the rest is taking up, is showing in the excretory phase, there is contrast in the rest of the pelvis. And this is without contrast. So in the without contrast, there is something lying inside, but you're not sure what it is. Unless you give contrast, you're not able to tell what is going on. All that you see is something filling up inside the renal pelvis. Again, a filling defect inside. When it is small, sometimes it can, there are a few other differentials like polyps or blood clots. They can also give you filling defects inside the renal pelvis. Then obviously you need to make sure that there is no blood clots or polyps inside. Okay, so the case number 5 is going to be trauma-related injuries to the kidney. So if you look at these kidneys, compare this normal kidney on the left side. What about this kidney now? Does it look normal? It doesn't look normal. You see there is a defect here, there is some defect here, and then there is some contrast taking up here. Okay, this part looks fine, this cortex looks fine, but where is the rest of the cortex? So there is disruption of the cortex here. And if you look around it, there is some fluid which is not taking up contrast. So remember, when the blood comes out of the kidney, it's not going to take up contrast. So again, another kidney, you see there is fluid all around it. And when you do a delayed excretory phase, you can see ureter on the other side. Here you can see some contrast in the ureter, but there is also some contrast which is extravasating, that is leaking out of the kidney. So if you have contrast in the delayed phase coming out of the kidney, and it would be something like this, contrast leaking out of the kidney, that means there is injury to the collecting system. So again, this is contrast leaking out of the kidney. This is not the normal renal cortex. So this is a shattered sort of kidney. Obviously, the patient is losing blood. He's bleeding inside. So when you have this condition, it's an emergency condition where you need to go in and sort of tie the vessel that which is leaking. Or, sometimes if you cannot save the kidney, you have to sort of do a nephrectomy in order to save the life of the patient. So these are the grades actually which tell you when not to sort of go in or operate on the patient and when to open the patient. So grade 1 is going to be just a subcapsular collection like this, a blunt trauma, and the kidney has a subcapsular hematoma like this. Grade 2 is again a larger subcapsular hematoma with 1 centimeter cortical laceration. Laceration means injury to the cortex. And when it is more than 1 centimeter laceration and the hematoma obviously subcapsular is larger in size, it is grade 3. Okay. Grade 4 is when the laceration extends to the renal pelvis and there can be injury to the collecting system, like the ones you just saw previously. And this is a shattered kidney when obviously the laceration is shattering the kidney. So you would see different, bits and pieces of the kidney enhancement. And sometimes some part of the kidney is not enhancing. Why? Because the blood supply is cut off to that part. So that means obviously there is a vessel which is leaking and you need to go in and clamp that vessel. So this is obviously going to be a dreadful condition unless you go in and sort of ligate the artery or the vein which is bleeding. The patient is going to die by losing blood. How much blood can you replace? So this is the one that you need to operate. So grade is according to, I've just said, grade 2 is when the laceration is less than 1 centimeter in the cortex. Grade 3 is when the laceration is more than 1 centimeter, but there is no injury to the collecting system. Grade 4 is when there is injury to the collecting system. So you would see urine coming out. So there will be urine around the lesion. So if you do a delayed excretory phase, there'll be, there'll be excretion of the contrast, extravasation of the contrast. It will come out of the kidney. So you will see fluid around the kidney. So it is known as urinoma formation. So the most common complication of renal blunt trauma is urinoma formation. Yes. There are a few ways, like as I've said, if you do a delayed excretory phase, you would see the contrast leaking out, because in excretory phase, it has to come from the collecting system. If you see blood in the arterial phase, which is the early phase, that means the artery is leaking. Understand? So the phases are very important in this case. So you do arterial phase, venous phase, and remember the ones I told you, corticomedullary phase and the nephrographic phase. So if you see any contrast coming out at that phase, that means the vessels is injured. If you see contrast coming out in the excretory phase, that is after 10 minutes of the study, after injection of contrast, that means it's more likely to be the collecting system which is leaking. You can also measure the Hounsfield units. Remember, the density of the blood is going to be more than 40 or 50 Hounsfield units, whereas urine is going to be around 0, because urine has the density of water. So if you measure the Hounsfield unit, it'll be around 0, it'll be below 10. So that can also at times help you. And even looking at the picture, with experience, you can tell whether this is visceral injury. And obviously the patient who's leaking blood would be clinically what? Unstable. Hemodynamically, if he's losing blood, he's unstable. He's in an unstable condition. So you know that there'll be a cytic fluid inside. So if the blood is leaking inside, you'll see a lot of blood collecting inside. The urinoma or urine collection would be just all around the kidney. So it'll be limited to the capsule. Remember the Gerota's fascia I told you? So the disease process is limited by those fascias. Don't worry if you don't understand. I'll show you examples. It makes more sense. So what do you do with grade 1, 2, and 3? Just conservative. Just keep them on bed rest, put them on analgesia, antibiotics, and observe. If it is grade 4 and 5, the management depends on the hemodynamic status. So if he's hemodynamically stable, you can wait and see. But if he's bleeding blood inside, then obviously you need to do an ultrasound fast. Fast ultrasound means you just go in and see whether there is blood inside the peritoneal cavity. If there is blood or fluid inside the peritoneal cavity, that means he's bleeding inside. Because in a normal person, you would not see fluid inside the peritoneal cavity. Okay. So free fluid, if you see on ultrasound, then you shift the patient to the OR immediately, because this patient is bleeding inside. And if he's stable with no free fluid, then you can also do a CT scan just to stage the injury to the kidney. So let's see an example now. This is a kidney taking up contrast. And if you look carefully, there is some leakage of the contrast in the excretory phase. So this is going to be what injury? The fourth one, okay? The 4th grade injury. Now, this is another one where you have fluid around it. You see, there's fluid around it. It's limited by the Gerota's fascia. So this is going to be a urinoma. So the most common injury or most common complication of blunt trauma to the kidney is a urinoma. So you just see some fluid around the kidney, which is limited just around the kidney. Okay, so you call it as urinoma. It's just a collection of urine. If you measure the Hounsfield unit here, it'll be around 0. So it's below 10. If it is blood, then it has to be above 40 or 50 Hounsfield units. Now, the problem with urinoma is they can sometimes get infected. So it has been there for some time. That is why you do a scanning like CT scan, just to see what size the urinoma is. If it's big in size, then you might need to drain in and put in a catheter. Okay, so remember the most common complication of blunt trauma is a urinoma. That's just a fluid collection around the kidney. These are usually stable patients. But the complication that would be that this urinoma might at times later on get infected. Then you need to drain these urinomas. Okay, so let's see a few examples. This is when there were trauma. The upper two are the cases of trauma cases. And if you look at these, they look very similar, but these are not trauma cases. So history is also sometimes very helpful. So in these upper two cases, there were history of trauma. So what do you see here? There is fluid around the kidney, okay? And you see the contrast is nicely taken up by the kidney, and you see the vessel going in. So there isn't any injury to the kidney in the sense that there is no, blood supply is not compromised. So it cannot be the fourth one, the shattered kidney. But if you look carefully, there is some fluid around it. So there is a urinoma formation, or there is some fluid around the kidney. So these are the ones which can later on get infected and form, infected urinomas, and then they might need to be drained. Whereas this one, if you look carefully, the kidney is enhancing, but this portion of the kidney is defective here. So you don't see any cortex here. So this is where the laceration is. And you see blood around it. So high density blood. Compare this density with this density. So there will be, this one is when you have a laceration which is more than 3 centimeters in size and is going to the collecting system. So what category would this be? 4. Okay. And if you do a excretory phase, a delayed phase, there'll be contrast leaking out. So it'll be category 4. So easy way to remember is shattered kidney is going to be grade 5 when you have vascular injury. 4 is when you have injury to the collecting system. Okay. This one, yes. When you have injury to the collecting system. Obviously, there would be some blood, with any trauma anywhere, you would have some mixture of blood. But if in order to see whether it is, that is why I've said the 4th and 5th category ones are the ones where you have to be a little careful. Is he actively bleeding or not? Because hemodynamic status is the one which is going to define. Sometimes you have a leaky blood which just sort of limits itself. So it gets, the vessel sort of just blocks on its own. So you don't need to go in those cases. But if it's actively bleeding, then you need to sort of go in and tie up that vessel. Okay, so what about this now? Very similar, it looks very similar to this one now. But this is not fluid. What do you think this is? Yeah, this is a mass. And from the pictures that I showed you earlier, what sort of mass was there in the mesentery, the para-aortic region? Lymphoma. So this is a lymphoma which is sort of sandwiching the vessels, is surrounding the vessels, the mesenteric vessels, and it has also gone and infiltrated the kidney. So don't mix this up. It looks very similar to this, but obviously there is no history of trauma in this. So this would also help you. But obviously with imaging, you know that this all cannot be blood. It's sort of, encasing these vessels. And what about this? You see patchy sort of striated nephrogram here, and then there is some collection around it. Pyelonephritis. Excellent. So this is what we saw in the last lecture. Sometimes you could have pyelonephritis, and you could have perinephric abscess developing. So this is a case of pyelonephritis, striated nephrogram, and this is, perinephric abscess being formation there. So again, there is no history of trauma in this case. Okay, the more common tumors in the bladder, as I've said, urothelial tumors are the more common ones, which are arising from the lining of the collecting system. Sometimes you could also see some calcifications in the wall of the urinary bladder. Do you know of any condition which results in calcification of the wall of the urinary bladder? No? Any parasitic infection? Schistosomiasis. Okay, so schistosomiasis can result in calcification in the wall of the urinary bladder. And sometimes you could also have stone formation along with the bladder masses. So these are transitional cell carcinomas, which are arising from the urinary. Always try to see the rest of the collecting system. It's not that they'll be only limited to the bladder. Sometimes you could have seedlings in the rest of the collecting system. So always scan the pelvis, the ureters, along with the urinary bladder. Okay, so prostate. What is the most common tumor of the prostate? No, tumor. We're talking of BPH is not a tumor, it's a benign condition. Adenocarcinoma. So adenocarcinoma is the more common tumor that you see by far in the prostate gland. Which zone is more likely to have the adenocarcinoma? Do you know the 3 zones? The central, the transitional, and the peripheral. So which one is more likely to have it? The peripheral one. Okay. So if I was to tell you, this is the central zone, and the transitional zone is actually a very sort of marginal zone, which is lying between the peripheral and the central zone. Okay, it gets enlarged when you have BPH like this. So the BPH changes are going to be in the transitional zone, which is lying between the central and the peripheral zone, whereas the tumor is going to lie in the peripheral zone. So whenever you are scanning the prostate gland, you try to see if there's any lesion inside the prostatic part. Okay, this is when you're doing ultrasound, and usually we do a transrectal ultrasound because it gives you more detailed images. But the imaging modality of choice is going to be MRI. Why? Because these days we are doing multi-parametric imaging. So what is multi-parametric imaging? Actually, we're making use of diffusion weighted image along with post-contrast images to see these lesions. We have pyrites classification, like you have pyrites classification in breast cancer. We also have a pyrites classification for prostate lesions. And according to that, then obviously we try to figure out whether it is, what stage it is. So remember, these lesions are going to be low signal. The adenocarcinomas are going to be low signal on T2 weighted images. They take up contrast and they would show restricted diffusion on MRI. So these three parameters are the ones which decide what sort of pyrite it is. I cannot go into more detail. Obviously, it's not beyond your, at this level, because obviously the classifications requires you to see a lot of cases before you can tell whether what sort of lesion it is. Because it's not that easy to differentiate prostatitis from prostate cancer sometimes. So just remember, adenocarcinoma is the more frequent tumor in the prostate, and it lies in the peripheral zone. Whereas benign changes, which is BPH, is going to be in the transitional zone, which is lying between the central and the peripheral zone. Okay, so this is an example of BPH, whereas this is an example of cancer in the peripheral zone, the right peripheral zone. So this is the peripheral zone. This is the central zone. Okay, again, this is the normal prostate, the central zone. The central zone has more glandular tissue. This is the white one, or the brighter one is the peripheral zone, this one. Okay, here you see the peripheral zone is sort of stretched out. Why? Because the transitional zone is taking up majority of the volume. So this is a BPH. Why? Because the peripheral zone is all stretched out at the periphery because of the growth or more tissue inside the transitional zone. There's another zone sometimes, if you want to know, this is known as anterior fibromuscular stroma. So you can also have some tumors developing in the anterior fibromuscular stroma. Okay, so this is an ultrasound of testicle. This is the epididymis, and this is the testicle on one side. So sometimes you have patients presenting to the emergency department with acute lower abdominal pain. And then you are to differentiate between torsion and epididymitis. So how would you do this? Ultrasound is the imaging modality. Obviously, it is easily available in every setting. So all you need to do is put color there, color flow. Just see blood supply to the testes. If there is blood supply to the testes, it cannot be torsion. Okay, understood or not? Torsion means that the blood is just cut off. So, and the patient presents with acute abdominal pain. If there is blood supply inside the testes, it is unlikely to be torsion. The other way, it's either going to be normal, or if there is increased vascularity inside the testes or epididymis, then it is itis, that is inflammation. Okay, so you see there is increased blood supply inside the epididymis here, and there is increased blood supply inside the testes. Okay, so this is a case of orchitis. Orchitis means increased inflammation or infection of the testes. Epididymitis means inflammation of the epididymis itself. Okay, so you would have epididymitis, you can have orchitis, or you can have them both together. If the blood supply is more in both of them, then obviously it is epididymo-orchitis. And sometimes you could also have hydrocele around it. So you will see reactive fluid around the testes. So there would be fluid in the scrotal sac. So not only there is increased blood supply, they would also have fluid accumulating, reactive fluid around in the scrotal sac. So this is known as hydrocele. Now, this is an example of testicular torsion. Usually children present with this. The children sometimes have retractile testes. So testes are sort of moving up and down in the inguinal region. So they can sort of have, they have more chances of, torsion there. So once you put blood supply again, you would see that there is no blood supply inside the testes, whereas the blood supply is more at the periphery of the testes. So the subcapsular part is going to have blood supply, but there'll be no blood supply inside the testes itself. Okay. Again, another example where you would have the scrotal part, that the skin would have blood supply. The skin around the scrotal skin or the capsular part of the testes would have blood supply, but there is no blood inside no flow detected inside the testes. Now, obviously, if it is acute one, you would also have edema inside. So the testes would appear, if you compare both sides, one would appear slightly hypoechoic, more fluid retention inside. Now, if you don't treat the epididymoorchitis or the infection, which is acute condition, then sometimes the patient can present late with testicular abscess like this. And how do you know this is not a tumor? You again put color inside. And if you see there is no blood supply inside this lesion or this area, that means it is an abscess. Why? Because abscess is a necrotic tissue. So the necrotic part, again, like you saw in the tumors of the kidney, would not take up contrast. So there'll be no blood flow to that part. So again, the Doppler or color filling is very important in this case. If you put color here and you see that there is no blood supply in this part, then it is more likely to be testicular abscess. It's not a tumor. So what is the more likely tumors? What is the commonest tumors in the scrotum? In the testes? Seminomas, okay? The seminomas are the more common ones. And then there's another one, non-seminomerous. These are all germ cell tumors, okay? So now you see that there is blood supply inside this lesion, which is inside the testes. If you see blood supply inside, again, the color filling is helping you out to differentiate abscess from the tumor itself. So ultrasound is an imaging modality of choice when it comes to evaluating the superficial structures, especially the epididymis and testes in adults. And prostate, as I've said, you can do it with ultrasound, but with multi-parametric imaging available these days, MR, you can plan out a better study and you can sort of stage the tumor according to that. And obviously, with the results that you get, sometimes you need to biopsy these cases. Obviously, you need to know what stage it is. Okay, so probably this is going to be the last slide. If you have any questions, you're most welcome to ask. Regarding the exam, it's going to be from this 2 lectures. You'll find the questions somewhere hidden in these slides. So no need to worry about anything. Nothing is going to come from any other outside source. Okay. Yeah, this is the normal one. This is BPH, and this is the prostate cancer. Yeah, most of them in computing, and you would have contrast enhancement and diffusion restricted diffusion weighted images. Okay.